Welcome back. Today our topic of discussion is on the hip flexors, exploring the biomechanics and pathomechanics of hip flexors. When we describe or when we tell the hip flexors, something that comes into our mind is these are a group of muscles that has a diverse role that help us in walking, running, jogging, or climbing stairs, or to stand erect, and various other tasks. So, it is very important that we know in-depth biomechanics as well as pathomechanics of these muscles for our clinical expertise. And something stands as an obstacle for us, which is that the deep location of these muscles, the most of these muscles or some of these muscles are deeply located within the abdominal cavity, and that poses a threat which which actually prevents the in-depth analysis and study of these muscles. What we are going to do today is understanding hip flexors with the possible and available literature. So let us discuss the hip flexors in detail. Let's continue our exploration of the hip flexors. First, let us see the anatomy of hip flexors. And biomechanics without anatomy is literally senseless. So let us learn first a bit about the anatomy. That is, the hip flexors. Which are the hip flexors? The muscles that are known to function as hip flexors, mostly many of you would know it already, which is the psoas major muscle. The second one is the iliacus muscle. The third one, it is the rectus femoris muscle. Rectus femoris muscle. Fourth one, it is the sartorius muscle. Sartorius. And fifth one, it is the pectineus. Fifth one, it is the tensor fascia lata. Pectineus comes as secondary hip flexors. Tensor fascia lata. TFL. Okay. So these are the 5 important hip flexors, and we call them by a unique term, that is the primary hip flexors. These muscles are known as primary hip flexors. And even in this muscle, you have a muscle which is more important or which is most important, and that muscle is the psoas major. This is the most important hip flexor. This is the most important hip flexors. But often we combine these both muscles and call them as iliopsoas muscle. Iliopsoas muscle. We call this both muscles as iliopsoas muscle, especially because both of them are seen in the pelvic cavity and abdominal cavity, and more than that, this has a common insertion into the lesser trochanter. We will discuss that later. But understand, we have 5 hip flexor muscles, mainly the psoas major, the iliacus, the rectus femoris, the sartorius, and tensor fascia lata. If we have primary, we will have secondary muscles also. Secondary muscles are adductor longus, adductor magnus, pectineus, and gracilis muscle. But why do we call it secondary? Secondary means they has some other function, and the name itself suggests they are the muscles of the medial compartment or the adductor compartment, and their primary function would be adduction. So these are the chief muscles that produce flexion, and those are the muscles that assist in flexion. They may not assist in complete range of motion. They may assist in few degrees of range of motion, either in hip flexion or when hip is in abduction, etc. So our point of interest or our topic of interest is purely understanding this primary hip flexors. And in that we have the most important primary hip flexor, which is the psoas major muscle. Let us discuss psoas major muscle. Psoas major muscle, right? Now, do you know anything about the origin, the insertion, the nerve supply of this muscle? One of the most important challenge that we face when we study about this muscle is its deep location. I told you just a few minutes before that the hip flexors, some of the muscles are located deep in the abdominal cavity, and it is tough for us to palpate and study it in depth. So this is the major muscle that poses the threat that or the difficulty that is a psoas major muscle. And there are number of studies, hundreds of studies about the role of hip flexor, especially psoas major. Some of the studies are contradictory. Some says that this has this function, some says that this has that function is not a relevant function of psoas major. We are going to discuss from the most available literature and evidence and arrive at a conclusion, a common conclusion at this point of time about the role of psoas major muscle. Focusing about the origin of this muscle, this origins from, you call it like a T12, thoracic vertebrae 12 to thoracic vertebrae 5, lumbar vertebrae 5, T12 to L5. That is from the lateral aspect of the vertebral body, thoracic vertebrae 12 to lumbar vertebrae 5. And the intervertebral disc in between them. And of course in the lumbar vertebrae from the transverse process also. That is T12 to L5 lumbar vertebrae lateral aspect, corresponding intervertebral disc, and transverse process of lumbar vertebrae. This is the origin of this muscle. And it is inserted into, as I told you, the insertion is on the lesser trochanter of the femur, right? The lesser trochanter of the femur, right? And it is supplied, that is by the L1 to L3 nerves, that is from the lumbar plexus. Now about the palpation of this muscle, let me ask you, is it possible to palpate the lumbar plexus, the psoas major muscle? Of course, it's a difficult task because this lies deep in the abdominal cavity. This was the muscle which I told you earlier, a few minutes before. The hip flexors are located deep in the abdominal cavity. We have a technique of palpation, which I'll be showing in next video, including the palpation, the tightness, identifying the tightness, and how to identify the different possible stretches, etc. for this psoas major muscle. Now let us focus on the biomechanics of this muscle, which is our topic of real interest. Now, when we evaluate this muscle's origin from various lumbar region and thoracic region, that is from T12, etc. And finally they insert as a small as a tendon into the lesser trochanter. And here you have the hip joint axis, right? And naturally, the momentum of a muscle would be the perpendicular distance from the joint axis, and this would be its momentum. And most probably, and because the joint axis, the axis of motion of hip flexion is passing through the femoral head. And now if we evaluate this momentum, I have just exaggerated this for your visibility. This momentum is very small. And we know that if momentum of a muscle is small, it cannot generate greater force generation because it will have less mechanical advantage. But we told the psoas major is the most important hip flexor. How is it possible? It is possible. Can anyone recollect it? Can anyone pick out what the correct answer? It is possible because this muscle have a greater physiological cross-sectional area. Yes, this is having a greater origin from 12 vertebrae, L1, L2, L3, L4. So they will be running from here to this lesser trochanter. So the physiological cross-sectional area of this muscle is high. If the physiological cross-sectional area is high, even though the momentum is lower, the muscle can generate greater force. And if the momentum is higher, even though the physiological cross-sectional area is lower, muscles can generate greater force. But here we have the muscle with a greater physiological cross-sectional area, which help the muscle to generate the maximum possible force. So if somebody asks you, oh, the momentum of iliopsoas or psoas major is very small, how can it be the chief hip flexor? The reason is it's a greater physiological cross-sectional area. Now, discussing more into this psoas major muscle, we told you that we discussed that the main function of this muscle is hip flexion. So this is a chief hip flexor, or most important hip flexor muscle. And studies shows that this is active throughout the hip flexion. Earlier we used to think, or some studies proved that this is only active in the terminal ranges of hip flexion or in the initial ranges of hip flexion. But now the evidence shows that this muscle is active throughout the range of hip flexion, that is from 0 to 120 degree or more. But this muscle has greater force generation capacity when the hip is in flexion. That is because, just look at this, it is very clear to understand. For example, let this be our thoracic vertebra, lumbar vertebra, where from this muscle is originating. And this, let it be the position of hip. You have your femur over here, right? And let it be our joint axis and whatever it is. Now this muscle has an origin and insertion like this. Yes, like this. Yes. See, this is the momentum initial. Okay. If the hip flexion is increasing, right, you call it, let the hip flexion increase this much. This one goes up like this. So naturally the momentum of the muscle also increases. If this is in the straight line position, okay, the momentum would be this. If this is a neutral position, the momentum would be very less. So this momentum of the muscle increases as we increase the hip flexion. So this muscle is capable of producing maximum hip flexion or maximum force when the hip is already in a flexion position. This is what we have to learn. So if you want to produce, or if you want to see when the psoas major is able to produce the maximum position, you sit in a chair. When we are sitting in a chair, our hip is already in flexion. And now if you ask the patient to flex the hip again, you need the hip iliopsoas. This is psoas major. This is hip flexion of 90 degree. If I want to lift it more, I need my psoas major. Without that, I may not be able to do it at all. These are the possible, the other possible examples. If you are driving, when you are driving in a car, you are almost in hip flex 90 degree. And you want to change from brake to accelerator your leg. That is possible because of this psoas major. You want to climb the stairs to your second floor of the home. The action is of hip flexor, right? So these are the daily examples where the iliopsoas is maximum active, and the reason is increase in the momentum as when the area or when the hip is already in a flexed position. And this help you to correlate more correctly in your clinical practice. If a patient comes to you and you are not able to identify which of the hip flexor is weak, you ask him to sit in a chair, you ask him to lift his leg. He may not be able to do it when he have a weak psoas major muscle. He will complain to you, sir, I have difficulty in climbing stairs. I am able to walk properly, but I'm not able to climb stairs. It is tough task for me. You can identify clearly the problem would be with your psoas major muscle. And if there is a slight weakness of psoas major muscle, it may not be palpable, may not be perceptible in your gait, because we studied that in gait there is only a need of hip flexion to 30 degrees. So if you want to identify hip flexion problems with psoas major, these are the positions. Now let us see the function of psoas major muscle. What are the functions? And similarly, if you're standing in unilateral stance and you ask the patient, you give a resistance, you apply a 5 kg weight to this leg, and you ask the patient to go for hip flexion, the iliopsoas, the psoas major will be recruited highly when there is a resistance happening, right? And now, along with hip flexion, we had earlier studied in your theory lessons that hip flexion along with medial rotation is a possible function of psoas major. But the latest study shows that psoas major has absolutely zero function in medial rotation. That is because already this is near to the joint axis. It is in the medial aspect, that is in the lesser trochanter. Okay, it is going through medial, it is going to medial and then turning and touching the lesser trochanter, right? Thus, the medial rotation momentum of this muscle is very negligible, and this has absolutely no chance of producing medial rotation. This is the latest studies. And about the lateral rotation, of course, this muscle has slight roll. The muscle has slight roll, especially in lateral rotation, because it is a lateral rotation, the joint axis is slightly away from the femur, and thus the momentum is slightly larger than compared to the medial rotation. So it has a light roll in medial rotation. So in the hip joint, the iliopsoas muscle, so psoas major muscle can produce hip flexion, can produce lateral rotation, but no medial rotation. Now this muscle is originating from the vertebra. Does it have any role in the vertebra? Can it produce rotation? Can it produce flexion, extension, anything in the lumbar vertebra? The evaluation of the latest study shows that this muscle has a crucial role in your lumbar vertebra. That is the stabilization of lumbar vertebra. That is the stabilization of lumbar vertebra. Because of this muscle's origin and its insertion, since it is passing from T12 to L5, this muscle function in such a way that it produces a compressive load onto this muscle, onto this vertebra. It produces a compressive load onto this vertebra, and this compressive force is actually going to stabilize your lumbar vertebra. And it is most important because most of your weight bearing etc. happens in your lumbar vertebra, the greater degree of the weight bearing, and thus you need a greater stability in the lumbar vertebra. And this psoas major muscle, due to its compressive effect, it is starting from 12, it is inserted up to the L5. So this compressive effect of this vertebra or the psoas major muscle is actually stabilizing your vertebra. How can we correlate this clinically? Can you think? That is because a patient comes to you with a herniated disc, right? He comes to my clinic, I give him all the modalities, I give him release and whatever possible physiotherapeutic management possible for that patient, I do him. I give him. He feels slight relief. And he imagine that he is a single person and he is coming from his home driving his car. After this release and after all these maneuvers, the patient goes to calm while riding the car. What can happen? That he can have an increase in pain. He may have an increase in pain. Why? That is because I told you the action of iliopsoas major is actually compressing your vertebra again. It is going to stabilize it. It is going to produce a compressive effect on the vertebra. And he's driving the car. Imagine when he's driving the car, he's already in 90-degree of flexion. Any other hip flexion requires the action of psoas major muscle. He is taking his leg from the brake and applying it to the accelerator. That requires his hip flexor activity. So he will have a greater chance of increasing the pain, because this muscle is going to again produce compressive effect in the vertebral column. So the better way of rehabilitation, especially if it is an acute onset condition, ask the patient to not drive, to not go for any activities that recruit the psoas muscle. That includes the walking, climbing the stairs, not walking, climbing the stairs. That includes, he goes to a bathtub and he gets up from the bathtub. Getting out from the bathtub actually requires your iliopsoas. Any activity that requires hip flexion greater than 90-degree, recruit the hip flexor, iliopsoas or psoas major to a greater extent. So advise him not to go for activities greater than 90-degree of hip flexion. If possible, avoid hip flexion greater than 45 degrees. That is the best way of rehabilitation. And that is the importance of this psoas major muscle. So this helps in stabilization of your vertebral column, your lumbar vertebrae. Now let us see, can it produce lateral flexion? Yes, of course it can produce lateral flexion of your vertebra, your lumbar spine, because this is attached on the two lateral aspects, and the contraction can produce lateral flexion. Yes, this contraction can produce lateral flexion, but the study shows that there's no role in producing lumbar flexion or lumbar extension. More than producing mobility in that segment, it is actually providing stability in that segment. So this psoas major is producing stability in the lumbar spine and providing mobility in your hip joint or lumbar joint and the vertebral joints, and in mobility in the hip joint. So the functions of psoas major includes hip flexion, chief function. Medial rotation, absolutely no function. Lateral rotation, yes. Stabilization of the lumbar vertebra, yes. Lumbar lateral flexion, yes, it has a great function. Lumbar flexion, absolutely no. Lumbar extension, absolutely no. There are studies saying that this muscle has some role in lumbar flexion and extension, but on the contrary, if you look at all the evidences, those two are less supporting ones. Maybe the future studies can prove they may have an effect and so on. Yes. And now discussing the pathomechanics of this muscle. What happens if there is a weakness of this muscle? Discussing the pathomechanics of this muscle. Pathomechanics. Pathomechanics. Weakness and tightness. Weakness and tightness. What happens if there is weakness of your psoas major muscle? When there is weakness of psoas major muscle, of course the hip flexion will be affected. Hip flexion will be definitely affected, and you will have difficulty in achieving the maximum hip flexion. As I told you, the patient will not have difficulty to walk or move around, because the maximum possible hip flexion for a normal level ground walking is only 30 degrees. So that may not be affected. So the most possible damage would be hip flexion activity, especially climbing the stairs, getting out of a bathtub, climbing the stairs, getting out of the bathtub, driving car, driving any other automobiles. These are the activities that will be affected to the most when there is weakness of psoas major muscle. And studies shows that after the 5th decade of life, there is a chance of there is a decrease in the physiological cross-sectional area of the psoas major. Already the momentum of this muscle is lower. So if physiological cross-sectional area is going to decrease, what is going to happen? The muscle is going to be weak. And that is one of the reasons why elderly people have a difficulty to climb stairs and balance problems, etc. That is the pathomechanics of psoas major muscle when it is weak. And what about when it is tight? When the psoas major is tight, what is going to happen? This muscle is tight, it is going to restrict your hip extension. When this anterior muscle is tight, it is going to restrict your hip extension. So hip extension would be limited. And if you have a tightness of psoas major muscle, this is going to happen. There is an anterior tilt of your pelvis. The pelvis can go for anterior pelvic tilt. Mostly the anterior pelvic tilt is caused by the tightness of iliacus muscle. Psoas major muscle also contribute to a greater degree, to a lesser degree, in the tightness of anterior pelvic tilt, right? When there is anterior pelvic tilt, your lumbar spine can go for flexion, your trunk can go for flexion. But in upright stance like this is something different. This is, okay, you can call this either as an open chain, you can call it functionally a closed chain, because my head is always fixed. As I told you in my earlier classes, for example, you can refer back. The link is given above, unilateral stance and bilateral stance. This is an upright stance position. And in upright stance position, your head is erect, your eye is on the horizon, and your neck is on straight, your head is on the trunk, above the trunk. The body's ability, or the task of this body, is to maintain this, to maintain the equilibrium. And now in the closed position, you go for anterior pelvic tilt over here. What will the body do to compensate this? The body will go for lumbar extension. And that lumbar extension can produce something like this. What is that? It can increase the lumbar lordosis. Imagine this like this. So here it is going for tightness. And this is being pulled over here. And anterior pelvic tilt occurs. What your body do? Body do in defense mechanism, it goes for lumbar extension, and this curve in the lumbar spine increases and can precipitate as increased lumbar lordosis, and can produce as increased lumbar lordosis. That is an applied aspect of the psoas major muscle. In a closed chain, the action of psoas major is different. In the closed chain, the psoas major can produce increased lumbar lordosis, even though it is going to produce an anterior pelvic tilt and lumbar flexion during the anterior pelvic tilt, right? And you can see this if persons who have difficulty in achieving lumbar flexion or lumbar spine mobility is limited, those people and people who have an increased mobility in the lumbar spine. So in both this group, if you see the hip flexor tightness, for example, the psoas major tightness, in people who have psoas major tightness with lumbar spine flexibility in a normal manner, you will see an exaggerated lumbar lordosis. But in old age people who have difficulty in lumbar mobility, you will see the lumbar spine is getting anterior. The spine and the abdomen goes for anterior, and there is a relative flattening of this curve. No lumbar extension, no lumbar lordosis, and these people will be having this sort of tightness, which is mostly seen in old age people. And people like us, healthcare professionals, IT professionals who sit for a long time can have a greater chance of your psoas major tightness, and those people can have an exaggerated lumbar extension, lumbar lordosis. And increased lumbar lordosis, there is a greater chance of producing lumbar spine pathology, which you have to take care. So the best way for us to stay healthy is do not sit for a long time in lumbar flexion, in the hip flexion, because that can result over a long run in the tightness of this muscle. So this is all about the mechanics and pathomechanics of psoas major muscle with available evidence of literature. It's a chief flexor. Medial rotation is absolutely zero. Lateral rotation is possible. Lumbar flexion is not possible. Lumbar extension, the role is very minimal. Not possible, it is minimal. Lumbar lateral flexion, it is having definite role. And it is a chief stabilizer in the lumbar spine as well as a mobilizer in your hip joint. And this can produce problem when you rehabilitate patients with IV disc or any other degenerative disc problems. And the difference in stance phase, if it is a closed gate of the closed chain kinematic movement or kinematics, it can produce lumbar lordosis. Increased lumbar lordosis is seen in common young adults, especially due to the tightness of your psoas major muscle. But if it is same in old age people who have lumbar spine mobility issues, it may not produce what you call the so-called lumbar lordosis, but it can produce a protruded abdomen. So this muscle is very crucial. So far the studies has not reached its peak to understand more into the psoas major muscle. Example, psoas major in running, in soccer, in any other activities, which we hope will be coming in future. So this is a great scope of interest and great scope of there is a great scope of research in psoas major as a hip flexor and lumbar spine. For winding the discussion, we discuss about the psoas major muscle, its origin and the action line. Just have a look at the following diagrams to have a clear understanding of the same. Now the insertion is seen in the medial aspect, and this is one of the reasons why the momentum is less for medial rotation, and absolutely there is no medial rotation possible with the hip flexors, especially psoas major. Cause the flattening of the curve in old age people, and as well as increased lordosis in young adults. With this we wind up the discussion on psoas major, and in next class we will be discussing the iliac muscle. Thank you. Stay tuned to my channel.